Hello, everyone, and welcome to the second episode of the RLI Power Hour webinar series. Tonight's topic is on creating value. My name is Jennifer Pendo, and I'm a program manager with the Radiology Leadership Institute. And before we get started, I'd like to review a few logistical items so you know how to participate in today's event. Here's an example of the GoToWebinar control panel. You should see something that looks like this in the upper right corner of your own computer desktop. When you join today's webinar, you selected to join either by phone call or computer audio. If you joined by phone call, please be sure to enter your audio PIN number, which can be found in the audio pane section of your control panel. And if for any reason you'd like to change your selection, you may do so by accessing your audio pane. There will be a Q&A session at the end of today's webinar. You will have the option to submit text questions by typing your questions into the question pane at the control panel. You may send your questions at any time, and the moderators will collect these and address them at the end. If you prefer to ask your questions verbally, please raise your hand by clicking on the hand-raising icon in the Grab tab in the top left corner of the control panel. We will call on you, and we'll unmute your line so you may ask your questions. Please advance the slides. Here's the schedule for the remaining 2 live webinars. Please make a note for Thursday, January 24th will be our next webinar series. Please advance. So without further ado, I'd like to introduce our program chairs and co-moderators for today's webinar. Dr. Rubin is a professor of radiology and bioengineering at Duke University. And Dr. Nathan is assistant professor of neuroradiology at Johns Hopkins Health System. I'd like to turn it over to them now.
Okay, can we go to the next slide then? All right, so thank you, Jen, for the logistics and running through all that. So I'd like to introduce tonight's speaker, Dr. Samir Patel. Dr. Patel is a radiologist with Radiology Incorporated in North Central Indiana, specializing in breast imaging. Dr. Patel is the founder and director of Radiology Incorporated's Value Management Program and has an interest in classifying, quantifying, and presenting the value-added activities performed by radiologists, which is why he's such a great speaker for this topic. He is a member of the Beacon Health System Board of Directors and also a member of the ACR Council Steering Committee and Technical Expert Panel. So with that, I'll turn over to you, Dr. Patel.
So thank you, Dr. Nathan, and thank you, Dr. Rubin. Thank you, everyone, for participating with this evening regarding an ever increasingly significant topic that is of importance to all of us in our practices in healthcare, and that is the topic of radiology value, and then specifically creating radiology value. So what we'll talk about during the next approximately 45 minutes or so is sort of our group's journey in radiology value and creating value, and hopefully share some concepts and some ideas that might be useful in your practice in the various environments that you practice in. So we'll describe radiology value-added matrix that we generated to sort of define, categorize, and quantify all the things that we do unrelated to film interpretation. We'll also talk about how to utilize that information in the matrix strategically in order to provide value to various sorts of stakeholders that we will be interacting with. And then finally, I'll share some specific examples of how radiology groups can add value in their practice environment, aside from just the image interpretation, with concrete examples from our own practice in highlighting some general concepts that will be of value. So a little bit about our practice. So my group, Radiology Incorporated, has been in existence for over 100 years, since 1904. We're a private practice. We have about 36 full-time equivalents. We're one of the 100 largest private practice radiology groups in the country. And our practice is primarily centered around South Bend, Indiana, North Central Indiana, between Indianapolis, Chicago, and Detroit. We're primarily hospital-based. We cover 5 hospitals and several outpatient centers. So when we talk about value, why are we even at this point? And it certainly seems like that we've been under attack for a long time. And the fact of the matter is, yes, we have. Imaging has been under attack since essentially the turn of the century. And the definition of DEFCON 1 is maximum force readiness. And it seems like we're all sort of under the gun these days to showcase What exactly do we bring, not only to our clients and patients, but to the healthcare system as a whole? And these battles are occurring on a local basis, on a state basis, a regional, national, and even an international basis. So to confound, not only are we under attack, but it seems like we're sort of caught holding the bag a little bit, because not only people associate that maybe we're part of the problem with some of the problems that I'll discuss with regards to imaging, but the interesting fact is actually most payments for imaging services are made to non-radiologists. Yet people, when we're talking about attacking, they attack the radiologist. But the truth of the matter is most payments for radiology services are in fact to non-radiologists. I'm going to advance the slide here for a second. I apologize. So this is also in the backdrop of healthcare spending in the United States. And this graph shows that progressively, not a surprise to any of us, that the percentage of GDP that is spent on healthcare is continuing to increase. And very soon we'll be approaching 20%. So not only is healthcare costs increasing in the country, but when we compare it to the rest of the world, in many developed countries, we are the outlier as far as healthcare spending. So this is yet another sort of attack or threat on imaging, because many feel that a significant portion of healthcare spending is related to imaging. Interestingly enough, when we look at all the regulations and all, sometimes would say layers of bureaucracy, when you compare the growth of healthcare spending with the increased regulations and requirements and all that, note that the amount of administrative oversight in a lot of these endeavors is growing at a pretty exponential rate when you compare it to the physician growth in this country. So these are the changes that we've already seen and are going to continue to see. One thing is for certain, and that's going to be changed. What things look like even next year or even into the future is going to be different than what it looks like now, just as it looked different compared to many years ago. Many radiology groups and practices and physicians themselves, we are going to have to adapt to change, because if we don't like change, we will probably be on the path towards irrelevance. And so adaptation is going to be the key. It's not going to necessarily be the largest radiology group, the most subspecialized radiology group, but it will be the group and the team and the practice that is most adaptive to change. And creating value essentially will be one of the key tenets of that. Radiology has two very unique opportunities when we talk about value-based care in this country. First is actually the number of patients that we see, and then second is with our imaging, we have a permanent patient conditions archive, or a snapshot of that patient at a moment in time where they have a particular healthcare concern or condition, or in the screening setting at a point in time where they are disease-free, for the opportunity to detect disease before it becomes clinically evident. So these are two unique advantages for radiology that maybe we can leverage when we talk about creating value. So when we talk about number of patients, it's not even a close race. Radiologists see more patients than any other specialty, and not by a close margin. So we do have a dramatic impact on healthcare. In our own practice, and this is data locally, our practice covers 5 hospitals and several outpatient centers. And these are the actual number of unique patients that our practice has seen over the past several years. We had a bump up from 2015 to 2016 because we acquired a practice that was near us and folded it into our larger practice. So that was the bump up. So what does this data mean? You know, these may just seem like numbers, but when we compare it to census data in 3 of the 5 counties that we're primarily based at, we image 20 to 30% of the population based on census data. A pretty massive footprint and a pretty massive amount of imaging that's utilized, and radiology is at the center of that. So what about permanent patient archive when it comes to value? Well, one of the advantages that radiology has is when a patient is ill, we can capture the patient's condition through imaging, and that capture of that condition is there for posterity. we do generate a report, and that adds some additional information based on the imaging. So let's compare this to a primary care physician or any other office-based physician. When they see the patient, they typically will do a history, similar to we do. They will do a physical examination and then document their findings. There would be almost absolutely no way to reproduce the patient's exact clinical condition at that time through the eyes of their healthcare provider, through their physical exam, as when you compare that to an image that we do. So when we look back at a patient's clinical condition and through office notes for a referring care provider for a patient, we can only look at the notes to try to get a capture of the patient's condition. Whereas in imaging, we actually have the actual sort of raw data, the actual capture of the patient's condition. And that will lead to very much more sophisticated analysis in not only evaluating the patient's condition in the imaging, but as a platform for future value. So when we talk about creating value, we must start out with technically what is value. And the definition of value is the regard that something is held to deserve the importance, worth, or usefulness of something. And it typically is a combination of perception and reality. And we all have our biases, both conscious and unconscious. And part of this is parlayed into what other people may view us as radiologists. And often, as this iceberg shows, people just see maybe the tip of what it is we have to offer, and that is film interpretation. But the fact of the matter is, if you look below the surface, there is a tremendous amount that radiologists and the field of radiology offers to the healthcare enterprise. Also, when it comes to value, it can be differences. And one of the differences, if we take some nomenclature from imaging modalities, from a spatial perspective, value can be different in my practice, which is located in North Central Indiana, versus the practices of all of you in your various regions, urban setting to suburban to rural, major cities, large and small. What may be of value may not necessarily be the same. Practice patterns. My group is primarily independent, but value may be different for an employed physician practice versus a non-employed. It may be different for a practice that's primarily hospital-based versus value for a practice that is primarily outpatient-based. And then temporal. What was of value, let's say, 10 years ago, 15 years ago, or even for that fact, 2 to 5 years ago, is going to be different than what is value now, and certainly what is going to be value next year, in 3 years, 5 years, 10 years down the line. So this is a formula that is probably familiar to many of you, the classic Cotter value equation, which is outcomes over cost. And what we want to obviously do is increase the numerator, outcomes, and reduce the denominator, cost. And doing one or a combination of both of those will increase value. So how can we now increase the value so that we can stand out from the crowd, so we're not necessarily lumped in? And so we are a unique differentiator, not even just as a field of radiology, but as an individual practice compared to practices that maybe aren't providing as much value to their clients. So the American College of Radiology has a great set of tools and initiative called the Imaging 3.0 Initiative. And essentially, it's a blueprint to provide all the things that radiologists must do, will need to do, will have to do beyond film interpretation in order to stay relevant and create value for the patients and our clients in the entire healthcare system. And the importance of this is going to be for all of us is really security and stability. Again, not just for the practice and us as individuals, but also for the field itself. So our story is, again, our practice has been in existence for over 100 years. And several years ago, our largest hospital client, with whom we had a relationship for over 100 years, and in fact, the founding person of our group actually helped found this hospital, they threatened to terminate our contract. So a 100-year relationship intuitively might seem valuable, but it may not be as valuable as you think. And part of the reason we came into this conundrum and why they were looking to replace us was because the perception amongst the leadership in the C-suite, the president who's actually shown here, and key physician leaders of the medical staff was, The radiologists, all they do is they read film. I'm not sure exactly what value they're providing to the healthcare enterprise. I'm not sure what value they're providing to us. We did not do a great job of showcasing and being aligned with the activities and the initiatives of our clients. So even 100 years may not be as secure and stable as you think. So we needed to innovate. And part of it with innovation, we needed to change the way that we were doing things. Not maybe necessarily doing more things, but just sort of really taking a look at who we are and how we're going to present ourselves. With innovation, it's often not about new things, but about new value. And so we chose, and there's very different ways for companies to innovate. And this diagram just shows various ways in which companies can innovate. And so we decided to focus on three things. We knew we were doing many things for creating value, but we just did not have a great platform and a brand. And we obviously were not really capturing and showing the story, telling the story, and making the story. So if we expand upon the value equation that I showed earlier, and this was our team's and our practice's modification of that, we decided to expand the numerator. So when we talked about outcomes, we extended it into 4 dimensions, which is very parallel in lean healthcare. The major buckets of quality, service, resource management, and professional development. So if we expand the numerator even further, this is where we come to the radiology value-added matrix. And so these are 36 items of various activities under each dimension that radiologists perform and oftentimes are very engaged with, spend a significant amount of time, but typically unreimbursed, not necessarily having a CPT code attached to it. But all these 36 activities are very indispensable to our clients, our patients, and the health system. The definition of a matrix is something from which something else originates, develops, or takes form. And this basically served as our new brand, our platform, that we were going to focus all of our activities around this particular diagram. And the goal was to invest time into each of these categories, or related to each of these categories, but demonstrate an outcome in each of these categories every single year. And year to year, they may be similar outcomes, but the goal was to touch upon each of these buckets. This diagram is not meant to be static by any means. And your practice may have a slightly different version of that, and that is certainly welcome. But we tried to capture most of the activities that radiologists do beyond film interpretation. So how do we capture, now that we knew the sort of the framework as far as what we were going to try to capture from the previous slide, how do we go about actually capturing that time investment? So what we started out was, and this was very sophisticated, several years ago, we started out with pencil and paper pads in each of the reading rooms, in which the radiologist, if they spent either going to a conference, a committee, spending time with technologists, this was the type of information that they would fill out. Well, several years ago, we subsequently graduated to an internally developed app, and now we can record some of this information electronically, and now we're just not logged and coupled to the reading room, because many radiology activities, and in fact most radiologist value-added activities, occur outside the reading room. They also occur typically after hours, on quote vacation time, on administrative days, and even on weekends. So now this platform is able to go with each individual radiologist whenever they're involved in a value-added activity. So we take the information, we would collate that, we would look at the number of entries on a particular month, collate them all together, and over the course of a year, we would aggregate all that data from the time investment standpoint. So what does the data look like? So this would be a typical bar graph that we produce every single year that looks at the value-added hours on the y-axis and the individual radiologist on the x-axis. So these are the amount of hours unrelated to film interpretation that we've got documented in our system, so that we can now share amongst our group internally the amount of value-added hours that every member is doing. Now you'll see that maybe some people don't have anything, and the reason for that is if somebody left the practice right after the beginning of the year and did not log in any value-added activities, or they just were newly hired before the end of the year and had not been engaged in any value activities, that was the most common reason. that somebody would not have any value-added hours. If you exclude those people in my group, everybody has some degree of value. And that is the strength of this. So how might we tie that to traditional work RVUs, which is a gauge of productivity that many practices utilize? So in the pink bar graph, the pink bars here is traditional work RVUs. How do we convert the value-added hours on the previous slide to the value-added units in order to get a total picture of what a radiologist does? So we would take the individual hours for a radiologist and then multiply it times the average work RVU per hour across all sites in our group, and then we would add it like we do here. So what has been the benefit of doing this? Now, we don't share names and we don't share the individual data with our clients, but we do share with names internally within our group. And this is really, it's a more accurate reality of the value that radiologists are involved with. And it really is meant to be symbiotic. It's a team approach, not a group approach. There is supposed to be variability. Some people will probably do more on the value side, and maybe also by linked to their particular office, such as chair of a department or chair of a hospital committee. But the people that actually do produce the work, it's also important that their activities are reflected here in the traditional work RVUs. Knowing that there's yellow on essentially every single radiologist really shows that we really do have a deep bench, and really there's a lot of people involved in value-added activities. We use this information to monitor and manage, but we do not have any minimum targets, either from a work RVU standpoint or from a value-added hour standpoint. And there's meant to be complementary heterogeneity. One of the benefits that we saw by sharing this data internally is the people that were reading the films had a greater appreciation of the actual amount of time the people that weren't reading the films were doing. So when they were often with the hospital president or talking with the CEO of the health system, this is now accounted, both activities are accounted for. So this has been the growth of our program. And part of this is not only by doing more, but actually also capturing more of what we're doing. So there's been tremendous growth and a sign of sustainability for creating value. And this has also increased on a per person basis too over the past several years. So how can one maybe set this up in their own practice? And so it really starts out with, I think, several key things. From people and management standpoint, having physician champions and also some degree of non-physician support, either with the secretary, would help. Leadership support from a group's executive board or executive committee will also go a long way. From a material standpoint, we started out with paper and pencil and Microsoft Excel spreadsheets. But figuring out how you want to capture the data, analyze the data, and what is your end product. And then from a process standpoint, it may be daunting to start out with all 36 categories, but maybe start out with the categories such as conferences, committees that you're involved with. And then also maybe consider a value committee or a small subcommittee of individuals to sort of define what we're going to capture and how we're going to present it. But the key is to present it internally and externally on a regular basis. Here's maybe a great way to get started. We give conferences, we allocate it at 1.5 hours each. Our conferences are typically an hour long, and we built in about a half-hour preparation. But your practice and your conferences may be longer, so you may decide that, our conferences take an hour prep. But we wanted to do this to get some sort of fixed methodology that everyone could agree upon so we can standardize this. And there's some other examples, and then you can continue to expand upon this list. So other people have showcased this work. We were fortunate to showcase this work in a publication in JACR in 2015, but other people have also published this too. And both other papers that I've shown here are from academic practices. Excuse me. They used a slightly different tracking mechanism. And if you look at the bottom line, the percentage of total work, what is clear is amongst all these different papers is we do spend a fair amount of time in, quote, non-interpretive, creating value-added activities. And this also holds true in academic practices, as the two papers have shown, especially from a funds flow performance, and maybe can be utilized for negotiating things. So what about, now that we have this information, it is absolutely critical to showcase it. So this is from a global survey of 400 CPAs, and many of them are C-suite members, that talked about that, yes, you need to report on your non-financials and the value of that for these 5 things. And actually, there's a much more exhaustive list. But yet, of these 400 participants, less than 5% stated that their entities currently did so. So how is the value story showcased? It is definitely important to showcase this to your clients. So this is strategically how we use that information. So we generate an annual report such as this, and our report from last year had 200 line items in it. And we put in over 15,000 hours, and we hit each one of those 36 categories of value. And the key is to demonstrate this and discuss this one-on-one with the leadership of your hospital. And it's always best if it's not just the same individual, but several individuals. So what might some of the value outcomes is from our list from 2017. So here I just shown, we participated in over 500 conferences, with over 17,000 radiology pathology correlations. We were very face-to-face with patients. We were on 27 different client committees. We have 2 hospital board members, 1 out of 5 members in our group on the medical executive committees, and some of the value work, which I'm going to showcase, actually a member of our group received the ACR Global Humanitarian Award last year. So what are some specific examples that you might do in your practice, and then also some key takeaway points from projects that we did? So one of the first projects we did several years ago was CT contrast standardization. Now, many of you are probably already doing this in your practice, but at the time that we looked at this several years ago, there was essentially no rhyme or reason. We had 3 different types of CT contrast, and you would ask the technologist what type of contrast to use and when, and the answers were all over the place. And so what we did was we looked to standardize some of that stuff. And what we ended up doing and showing was it translated into between $800,000 to $900,000 of cost savings for the hospital in order to standardize this. And one of the things that we utilized was the ACR contrast manual and ACR appropriateness criteria in order to figure out exactly which type of contrast we wanted to use. So the key takeaway point from doing a project like this, from creating a value standpoint for your clients, is if you can tie a financial benefit to your clinical improvement activities, it will capture the attention and amplify your message even more. What about collaboration with other people within radiology? So interventional and diagnostic radiology, collaborative efforts can go a long way in creating value, and we have done this locally. So carotid CTA is a very common exam. When we looked at this several years ago, we thought we were doing a good job until we actually did a deep dive and found out that many of our patients were being excessively radiated, and also our reporting and acquisition was also suboptimal. So we conducted a root cause analysis, and we implemented some practice improvement key initiatives and fixed this both collaboratively with our interventional and diagnostic radiologists. And again, what we showed to our clients was marked reduction in radiation dose and a significant reduction in reporting defects per report. So what did this also benefit the client in addition to these 2 remarkable benefits? Well, there was appropriate revenue enhancement because we were having to undercode for exams because we didn't include the correct documentation. So again, creating value, doing a project, collaborating with others, tying a financial benefit to that will amplify the message. Collaborating with other specialties is another tremendous way to create value. And this was actually my lean black belt project that I had to do. And we worked collaboratively with the emergency department physicians. And one of the problems what was occurring is a significant number of emergency department patients were not receiving the appropriate CT exam from a contrast perspective. There were patients that were not getting intravenous contrast that should have been getting contrast, and vice versa. There were also patients that were unnecessarily getting oral contrast with the subsequent delay waiting in the emergency room when they really didn't need to. So we worked collaboratively with the ED physicians and increased the value of our ED imaging by increasing the appropriateness of when to use oral, when not to use oral, as well as intravenous contrast based on ACR appropriateness criteria. There was a marked reduction in variation, and the reduction in ED patient length of stay, we quantified that in terms of dollars potentially saved to the hospital. And that number averaged between $250,000 to $500,000 per year. So how about creating value within the context of, from the Institute of Healthcare Improvements perspective, of the triple aim, which is improving the health of populations improving the patient experience and reducing per capita cost. So how can we maybe do something in imaging to create the value that addresses all these three things from the triple aim? So this is what we did as far as at two different time points, and these were a decade apart at my current practice. So we looked at in the numerator the total imaging cost, professional component only, of breast cancer diagnosis. So this included screening mammograms, diagnostic mammograms, breast ultrasounds, biopsies, everything up to the point of breast-conserving surgery or mastectomy. What was our total cost during the course of a year? And then in the denominator, what we included was the total number of breast cancers, and then also we looked at the survival into the denominator, such that if we were spending the same number of dollars, but we diagnosed all stage 1 cancers, that would actually be more cost effective than if we diagnosed all stage 4 cancers. So we built that into our formula by utilization of 5-year survival. So what did this type of study show for our clients and for our patients? So what it showed was we reduced the amount of professional imaging costs per number of breast cancers diagnosed by 26%. And then when we indexed it to early stage breast cancers, that number was decreased by 32%, so a lot more cost effective. And how did we achieve this? And this was through a combination of increasing cancer detection, reducing our recall rate, reducing inappropriate diagnostics and short-term follow-ups, and increasing subspecialization. We had some people that were just bordering on the number of required mammograms, and so we shrunk the pool down, and then we saw these outcomes over the course of a decade. So tying this to money and the triple aim is another way your practice can show and create value for your clients. We can create value by increasing visibility to our patients. And so the ACR Imaging 3.0 initiative has over 100 case studies of how we can showcase value, and 26 of those case studies talks about patient engagement. So how did our practice create value from interacting with patients? So for 7 years now, we invite patients at our thoracic conference actually to the conference. And you can see here, they're sitting at the head of the table, and all the healthcare providers are flanked along both sides. We go over their imaging, their pathology, we answer questions. To date, we have had over 500 patients now attend this. And we talked about a little bit more in details and gave some updated information at a recent American Hospital Association webinar that I gave with the Vice President of Operations. So including patients can be a great way in creating value in your value story. What does this mean for the practice? Well, there was a greater degree of connectedness with the patients. And one patient we actually had that showed up a couple months ago who was diagnosed with stage 4 cancer, loved the process so much, she thanked all of us for treating her like a queen. And those were her exact words I quoted. So here's a patient that has stage 4 breast cancer, and we're talking about her treatment plan with her present, and she is thanking us. In an era of burnout, we often don't get great feedback and sometimes may not feel appreciated, but we have found this has been such a benefit not only to our patients, but also to our medical staff also. A spin-off of this has been, again, further collaboration, and we've reported on this, where we take one piece of value and create another piece of value on it. Many of the patients that we see end up having CT-guided biopsies. We found that through a practice improvement project, we significantly reduced our radiation dose for CT-guided lung biopsies because we were starting to see a greater number of CT biopsies from our thoracic screening program, which we did in conjunction with the program I just mentioned. So it's certainly better together for the patient's community and our health systems. So there's often activities that we do, and all of you have done, and all of you will continue to do, and maybe all of you have been involved with, and that is the purchase of equipment. And so every piece of equipment has a certain lifespan. And so several years ago, we had the same situation. We had an old CT scanner, and that needed to be replaced with a new state-of-the-art for greater capabilities. And traditionally, people think, oh, we'll just trade it in, get the money back, and then move on from there. So the gentleman in the screen to the left is our group's practice chair of the executive board, Dr. Al Harding, and he was involved in several local endeavors. And one of the endeavors he was involved with was with Andean Health Development. and they were in the process of building the Theodore Hesburgh Hospital in Santo Domingo, Ecuador. So Al knew that we were going to be replacing a CT scanner. This facility in Ecuador was looking for a CAT scanner, and so we found a way to get the CAT scanner down to them and donate it to them. Goodwill on our part, and for something that the scanner was not deemed of value to us, but then we found a way to share it with someone else. So you never know sometimes what a kind of action can lead to. And that's Al Harding receiving the 2017 Global Humanitarian Award from Dr. Howard Fleischon, Vice Chair of the ACR Board of Chancellors. So the story doesn't stop there. So several years ago, there was a massive earthquake that shook Ecuador in this region. So this is a letter from a medical student who was actually down there, and she shared it with us afterwards and talked about how devastating it was to the community and everything down there. But I highlighted a key portion of a sentence in there, and it says, most patients required imaging, which luckily we have access to CT and X-ray here. And that was our CT scanner that we had donated. And so you never know, what you might think is a trivial action, what you might think is not even a value, what downstream value it could have for someone, not only locally, not only nationally, but even potentially internationally. How about creating value from a perspective of interacting with vendors that maybe many of you already do from a product development and testing? Well, this is a great way to create value. And our group has been fortunate that we've been able to provide design input for 8 commercially available devices and software that are utilized currently, not only nationally, but internationally. So what might that mean for the individual radiologist practice? Well, oftentimes it gets clinical tools and hardware and software in their hands that has been partially designed by them to meet their needs. What might it mean for the vendor? Well, it's an additional validation and feedback from potentially a different practice setting. So maybe not all the validation and feedback was done at an academic center, but maybe now there's some experience from different practice settings. So how about from the client's perspective? So the hospital, so for instance, for us, well, what we negotiated was we would work with the vendor, so we get the practice clinical tools, we spend time designing, giving design input, the vendor gets the product, and then they can negotiate a contract with our client, potentially for price reduction. And that has been sort of a win-win-win all around. Creating value definitely has to involve the C-suite, and increasing visibility with the leadership is key. And so there's tables around this across in every location, and it occurs on the local level, the state level, the national level. And so having periodic scheduled and unscheduled interactions with members of the C-suite is a great way to create value. It is important to remember that C-suite members are typically involved in meetings all day long. We may go to a meeting, but then go back to our reading rooms or other practice settings. But they are going from meeting to meeting to meeting. It is great and be refreshing to start out a meeting with something positive or something new. You don't need to wait until at the end of the year and just have the one meeting to go over the annual report. This is a continuous process. Always continue to share how a unique differentiator not only is your individual practice from maybe other practices in the same field, but also other fields. Definitely be involved in investment in the organization. As I mentioned, we're part of over 27 different client-based committees, and 1 out of 5 members in our group is on the medical executive committee at our hospitals. So being present is certainly a great way to show your visibility. When performing performance improvement actions, and there will always be performance improvement actions like I've showed before, tying financial benefit to that will not only amplify your message, but even create greater credibility. And for every meeting, or if it's an initiative that they bring, definitely don't start out with no all the time. And in fact, actually, our thoracic program where we invited patients, it was an idea that several members of administration had, came to us. We talked about it. We didn't say no right up from the front, and here we are 7 years later. So the key is nature abhors a vacuum. If you're not at one of these tables, somebody else probably is. And it's important for everyone sitting at this table to have a good understanding. And obviously, if we can fill one of these seats, that would be great. Some of these initiatives, when we talk about creating value, whether it's new piece of equipment, new hardware or software, will probably require some capital. And some of the mistakes that many people make is to take a very small and myopic view of things and maybe don't hire or involve appropriate staff. They don't invest in significant amount of space or equipment, or they focus too much on price or some other things. So these are some mistakes that it's important to highlight in order to create value. Is there might be a little short-term investment in quote loss, but the downstream gain will be so tremendous. So in summary, it's definitely important to acknowledge, quantify, and invest in a lot of things that we do. And your practices are all doing so many wonderful things. And it'd be great to share that story with all your constituents. This is not just a once and done deal. This is a continuous process, and not just even on an annual basis, but even on a monthly basis, innovating and improving. And then collaborating with others, even within the House of Radiology, Diagnostic, Interventional, and then outside the House of Radiology with other specialties, and even non-physicians will be key. And what really you don't want to do is maybe do one good thing and then book a business on that one great thing and always use that. Because that's unfortunately what we did, is we booked our business to the fact that we had a 100-year relationship, but we didn't continue to innovate. And then I'd like to say now that we sort of learned our lesson, and we certainly do not want to be a one-hit wonder. So with that, I will end, and thank you for spending your evening. And hopefully maybe the wheels are churning now so that you can go ahead and improve and enhance and tell your value story to everyone else. Thank you.
All right. Thank you, Dr. Patel. This is Jeff Rubin, and I am going to hopefully spur some questions and discussion amongst those of you who are in attendance with us. And let me just amplify the message that was a terrific presentation. Hopefully everybody got a lot of ideas and has a lot of thoughts about value creation by radiology. A lot of dimensions discussed by Dr. Patel. There's two ways that you all can engage in asking questions. One is you can type a question into the question pane, and then I'll be happy to read it and present it to Dr. Patel. Alternatively, you can raise your hand, and we will unmute your microphone, and you can ask directly. So don't be shy. When you're ready, please jump ahead, and delighted to see our first hand raised by the ever available Dr. Ian Weissman. Ian, please go ahead. Oh, wait a minute. Let me unmute you again.
Dr. Weissman, it looks like you may have muted yourself. You need to unmute yourself by clicking on the microphone.
There you go.
Right. Hi, Jeff. Hi, Samir.
Hey, Ian.
Just tremendous job, Samir. Just tremendous work and fantastic presentation. And I always love hearing you talk about this, and I've learned so much from you and everything you've done. I have a question. Have you been expanding your value-based matrix recently to add more metrics to what you're doing? What are you going forward? What have you been thinking about? New ideas? I'd be curious to hear about that.
No, thanks, Ian. And I know you're doing a lot of great work with engagement of patients and everything. So, but thank you for the question. And so, yeah, so again, we don't want to be a one-hit wonder. And so what have we been up to lately? And so a couple things. One is we continue to capture different sorts of activities. We actually added a couple new categories. We added a category on physician well-being. And so, for instance, we now have regular social events scheduled, sanctioned by the group, so that we can collaborate and just have, whether it's a sporting event locally or a dinner with spouses. So that's one way we've tweaked the matrix a little bit. from an outcomes perspective, last year we put in over 200 line items, and several years ago that number was under 100 line items. So what were some of the things we included as far as from an outcome? Well, being in a macro and MIPS world, we included a lot of the MIPS measures that our group was participating. So not only did we show we were participating more than just the 6 minimum required MIPS measures, we demonstrated our actual outcomes on those in reference to national databases such as the various ACR registries. So those are just a couple of the things that we've done to continue to not only increase the categories, but also increase the number of metrics that we show.
Super. We have a question from Dr. Liu, which is, do you distinguish radiologist reimbursement based on non-clinical versus clinical duties, and why or why not?
Yeah, so essentially what we include, so the question might be, if I'm hearing this correctly, is what might be considered value. So the things in the matrix are things that are unrelated to billing of a CPT code, or unrelated to the particular procedure itself. So if I'm doing a procedure, let's say a CAT scan, but I don't have the complete information, and I need to either talk with a clinician about that patient, well, referring provider communication is one of the buckets. Would that qualify as value? And in our instance, in that example, the answer would be no, because that particular collaboration is specific to an exam, and that has already been built in on the reimbursement process. So we try to differentiate what might be considered CPT versus what is not. And again, that's where we started out with conferences, committees, and then expanded to various different things. But that was sort of our sort of fine line was, does this have a billable CPT code or doesn't it?
Now, what about physician compensation, radiologist compensation? Are radiologists in the practice compensated equally for traditional work RVUs as well as the value RVUs, or is the compensation plan completely independent of the non-clinical value component?
Yeah, no, that's a great question and very relevant, because oftentimes, depending on how someone's contract or employment agreement is written, does it make more sense to spend more time reading or spend more time doing value-based activities? So a couple of things of how our matrix has helped us define and what we do. First is all of us get paid the same. A full partner gets paid the same, and so we're not compensated based on individual work RVUs. The second part, as far as the value is concerned, is we don't have any minimum targets. We don't mandate a certain number of minimum value hours. But how this has helped our practice is there typically might be a couple people in your group that may be doing way more, such as a practice president, such as a member of the practice who's chief of staff, and they just have an inordinate amount of hours. Well, having this type of data actually then allowed us to, we didn't necessarily compensate members, but we give them additional time off. And then we have this data to justify that, okay, this person is putting in this many hours and is required for this many activities, so they need to get more time in order to do this. So that is how our practice does it, but I totally understand that every practice may want to either tie or maybe have sort of a hybrid model where they do compensate partially, but that's just one example.
Terrific. Now, Dr. Abramson would like to first say that it's an extremely impressive value management program, which certainly took a lot of time and effort to build. Time and effort that would have come at an opportunity cost to the practice. At the time that you began to develop the program, were you challenged to articulate to the practice the return on investment of the value management program itself? And if so, how did you forecast its anticipated future returns in order to convince the group that it was worth the effort?
Yeah, this was, when I look back upon this now, the initial steps, you're right, I didn't anticipate this much success or longevity. So now as I look back upon it, what might be some key takeaway points for people if they're thinking about doing this? So there were several things that I did to ensure that we got success right off the bat. First, we had a pretty significant burning platform. If we didn't show something really soon, our contract was going to be terminated. So that was our burning platform. And it was a pretty strong burning platform. The second thing was I didn't ask all the practice members, and we started this just at one location. We didn't start it enterprise-wide. We only started at one location where I was the chair of the department in 2012. And what I asked for the radiologist was, just tell me all the things that you're doing, okay? I'm not asking you to do more. But if you're doing other things and if you're feeling especially stressed out by all those other things, just tell me what you're doing, and I will be sure to share your story. And also, you'll also want to see what your other colleagues are doing. For the people that were doing a lot of these value activities, they felt they weren't being recognized. So I approached them and saying, this was the way that you can share your story. You tell me, and I will share your story. And then the third thing was we got the president, who I showed in our ACR Imaging 3.0 case study. After I had 6 months of data, I showed the president of the hospital. And I went over everything with him and what we had. And his comment to me, and I still remember this to the date, is this is what we wanted to see all along. You tell your group members that this is what we wanted to see. And this gives us a better understanding. And now we will be one of your biggest advocates. And so I took that back to the group. And then subsequently, the president actually talked to several other people in our group. And so having one of your clients, vouch on your behalf. And then we took that story to another hospital, to another hospital, to another hospital. And then the last thing we did was we tied it to some financial incentives. We tied it to some medical directorship fees. Now, the amount of hours that we put in far exceeds the small amount of medical directorship fees that we give. But that was the justification and the opportunity cost investment that we did up front. Preservation of the contract, which I think is almost invaluable. And then stability of the practice. And then I will tell you that we've renegotiated our contracts with these same C-suite members that were going to eliminate our contract several years ago. The last two contract negotiations have gone so much better and so much smoother because we continually provide with them this information. So I think that's the return on investment of the opportunity cost.
Terrific. Now, when you described the burning platform, it was pretty clear who was the critical stakeholder in demonstrating value too, and that's the hospital. When you think about all of radiology's stakeholders, be they referring physicians, be they patients, be they payers, how do you look upon the spectrum of value-producing activity and ask the question, where should we allocate our value? To which stakeholders, and how do we divvy up that value effort?
Yeah, so no, that's a great point because, I've come up with 36 categories, but there's certainly way many more things. And there's so many things that are important, and it seems like we're all being pulled in so many different directions. So it almost becomes a triage as far as what endeavors, even on a national basis, where we want to spend time and resources. And part of this is if we look at the different stakeholders, and I kind of group them into sort of three main categories. One is definitely the patients. Two is definitely the payers. And then three is the referring clinicians or our colleagues. And so what are things that we can do in the overall scheme of healthcare that can improve things that are important to them? So this would require actually an invoice and taking an intake as to what are the most important things to them, and then maybe how can we as radiology and radiologists can answer some of those things and provide value in each of those things. The other thing is oftentimes, and in many practices, some of the things are financially driven. So we can tie many things together, such as with macro and MIPS, and as payments are being transitioned to non-fee-for-service, is maybe we need to focus on activities that maybe are not only revenue enhancing, but potentially avoidance of a loss. Avoidance of a loss is just as much of it as a gain. So we spent last year spending part of our matrix time, so to speak, on the macro and MIPS measures because we had some work to improve on there. So for that aspect, we use finances. And unfortunately, in many situations at local, national, and regional levels, often it may come down to finances.
Along that line, with so much attention to value-based care, and in particular to the principle of bundles of care, how do you see using this framework to address internal revenue distribution associated with a care bundle? For example, let's say that the system has contracted for a knee replacement bundle and that there is a fixed payment that is coming in for care associated with it. You're going to sit at a table with orthopedists and with internists and anesthesiologists, as well as various departments from the hospital, and everybody's going to argue for the relative value that they're contributing to the care of the patients. Have you considered how your system can help in order to assure that radiology gets a fair shake in that?
Yeah, no, definitely. That's and that is part of this is yet to be answered, but I think it's a great place for radiology to be. So if we go back to one of my slides where I talked about the sheer number of patients that we see, and oftentimes radiology will actually see more patients than are potentially eligible in some of the bundles, or to identify the patients to eventually get into a bundle. And I think that's where radiology can be a key primary driver to maybe direct what patients can go into a particular bundle. And also, once they get into the bundle, how can we expedite the care? How can we, provide all the imaging that may be needed, but then also maybe in certain bundles, maybe say that, imaging is not necessary. But if we're investing that degree of time and investment, which will probably require multiple meetings and will have multiple outcomes, that could be the basis for a percentage of the payments. And one of the things that we showed in the breast cancer model, so if there was a bundled payment, let's say around breast cancer and breast cancer diagnosis, well, the data that I showed is a directly impactful way that radiologists can then justify a percentage of those savings because they will have had a direct impact. And it may be easier for certain clinical conditions than other clinical conditions, but it certainly imaging will touch upon very many different bundled payments for various clinical conditions.
That's marvelous. Well, at this point, I think that we want to draw the hour to a close. And so I want to hand the microphone over to Dr. Nathan to provide us with a little bit of a summary. And before I go, let me just express my great appreciation to Dr. Patel and to everybody in the audience for your participation. Jen?
Okay, thank you, Dr. Rubin. So first of all, I want to thank Dr. Patel for an excellent presentation on such an important topic and also providing insight on building value. And I also want to thank our attendees for participating on tonight's Power Hour webinar. Here we go. I got the next slide up. So a few things I just wanted to remind everyone about before you go. Our next Power Hour webinar is titled Achieving Alignment with the Healthcare System, and that is scheduled for Thursday, January 24th at 8 p.m. Eastern Standard Time, so mark your calendars. We will be sending you a GoToWebinar confirmation email following this webinar, so please save it on your calendar. Also, we'll be sending out a post-webinar survey, so please take some time to fill this out and provide us with feedback. We'd greatly appreciate it. And if you want to go back and review some of these important concepts, we will have a recorded version of this webinar available and posted next week. We'll send you an email to let you know when that is posted. So thank you to everyone and have a great night.